Hello, I'm Mary Tinetti, Chief of Geriatrics at Yale. Over the next several minutes, I'm going to introduce you to patient priorities care, which involves identifying each person's most desired health outcome goals, given the healthcare they are willing and able to receive, and then aligning care to achieve these goals. Patient priorities care was developed with input from clinicians, patients, caregivers, and many others. In this introduction, I will describe what patient priorities care involves and who it is for, explain the complex problems that aligning care with patients' own priorities helps address, and discuss what we have learned from sites and practices that have already implemented patient priorities care. I will finish by introducing you to what healthcare teams need to do to get started. You will learn more about that in subsequent trainings. Who is a good fit for patient priorities care? Disease guidelines work reasonably well for persons on the left, taking into account their healthcare preferences, of course. On the other hand, a focus on symptom management and palliative care is appropriate for most people with less than 1 or 2 years life expectancy or with very advanced illness. Acknowledging their priorities and considering that everyone with chronic illness can benefit from symptom and palliative care. While patient priorities care is appropriate for everyone, it is particularly good for the middle group, patients with increasing numbers or severity of chronic illnesses, functional limitations, and concerns about life expectancy and health trajectory. This group includes at least 50% of persons 70 and older. These are the individuals who are the major users of healthcare, but for whom individual disease guidelines may not apply, and for whom decision-making is most uncertain. I will explain. We know that care for older adults with multiple chronic conditions can be of uncertain benefit. There are a few key reasons for this uncertainty. First, these individuals are not included in most of the clinical trials used to inform guidelines. We don't know if results apply to patients who are very different from those in the trials. Second, older adults with multiple conditions may have less benefit than suggested by the trials because their other conditions affect overall health and response to other treatments. What's good for their heart disease, for example, may not be good for their depression. Most importantly, what are the outcomes we should use to define benefit? Is it that they don't have a heart attack or that they don't break their hip? How do you compare? Disease-specific outcomes and even survival doesn't get at the variable outcomes that matter most to individuals with multiple conditions. We also know that unintentional harm occurs when considering conditions in isolation of each other. For example, 1 of 3 older adults with multiple conditions is prescribed a guideline-recommended medication that may be appropriate for one of their diseases, but is likely to harm a coexisting condition. But that's not all. We all want to live as long as possible, remain functional, and not have to work at it. But there are trade-offs, particularly for persons with multiple conditions. If you ask people what matters most, their responses vary, with 42% of older adults with multiple conditions saying that maintaining their function is most important, even if it means not living as long. About a third say relief of symptoms such as fatigue and pain is most important, while 27% say they want to live as long as possible, even if they're not as functionally or physically active as they had been. One person may prioritize being less tired so she can take care of grandchildren, while another person with the same combination of conditions may prioritize being free enough of pain to be able to hike or knit or continue paid work. What defines benefit is very individual in this group of persons. What's right for you may not be what's right for me. People vary not only in the outcomes that they most desire, they also vary in the healthcare, such as medication effects, healthcare visits, testing, and procedures that they're willing and able to do or receive. Healthcare can be burdensome for older adults with multiple conditions who spend an average of 2 hours every day on healthcare tasks and a half a day every time they encounter the healthcare system, whether it's for an office visit, diagnostic test, or procedure. The things we so easily ask people to do take time and effort away from how they'd rather be spending their life. In Patient Priorities Care, we address these issues by focusing on the health outcomes people want, given the health care they are willing and able to receive. Aligning care with what matters for each person is helpful, not only for patients, but also for clinicians. Providing care to persons with multiple conditions can be frustrating. Uncertainty means there isn't a right answer, but our brains are hardwired to have the right answer. We want to do the right thing. So I may be sure that that patient should stop a medication. You're equally sure she needs to continue it. This false certainty can lead to conflicting recommendations among colleagues, particularly if we all focus on our own disease and perspective. It is also frustrating for clinicians when people don't do what we want them to do. The clinician thinks, that patient isn't adhering to what I think is best. The patient thinks, I can't do this, or this won't help me do what's important to me, so why should I do it? We're all looking at a different part of the elephant. It can be frustrating for everyone. Patient Priorities Care provides an anchor for everyone to use decision-making in the face of this uncertainty. If we don't know what is best, and patients vary in the outcomes that matter most, and what they're willing and able to do, what else should we align care with except each patient's own health priorities? To be clear, clinicians can and should express their views and perspectives. For example, I might say, I see that what matters most to you is getting off this medication because it makes you too tired. Is it okay if I tell you what my concerns are about that? Patient Priorities Care moves decision-making and conversations from a focus on a single disease. You need this treatment for that disease, such as you need to take another blood pressure medication, even if it makes you tired, so you don't have a stroke. It focuses on the person, knowing all your health conditions, what's happening in your life, and what's most important to you. I suggest we try. And here you fill in what you think is the optimal intervention to achieve this person's goals that is consistent with their preferences. This approach acknowledges that the patient is the expert in what matters most to them, while the healthcare team members remain experts in their own areas, whether that be primary care, specialty care, therapy, care coordination, or whatever. We each use our expertise to help patients achieve their priorities. There are only 2 steps to Patient Priorities Care. Identify a patient's health priorities and align care with these priorities. By health priorities, we mean the health outcome goals, the thing patients most want to do in their life that they want their health care to help them with, given their preferences. That is, the healthcare tasks, medications, procedures, and healthcare visits that they are willing and able to do to achieve these outcome goals. After identification, these priorities are shared with the healthcare team. The healthcare team, patients, and care partners then work together to align care with these priorities. As you can see, this step has 2 parts. First, when the focus becomes achieving patients' priorities rather than solely treating each chronic condition, it is necessary to consider which current or potential interventions are most likely to help the patient achieve their most desired outcome goals while being consistent with their healthcare preferences, what they are willing and able to do. To align care, everyone, the care coordinator, primary and specialty clinicians, therapists, patients, Everyone uses the patient's priorities, not just their diseases, as the focus of communication and decision making, as the target of serial trials to start, stop, or continue interventions. Remember, it's not just getting rid of care, it's realigning care, and to reconcile decisions when there are different perspectives, either among clinicians or members of the healthcare team, or among clinicians, patients, and care partners. Because things change, it's an ongoing process. But don't worry, it may seem awkward and unwieldy at first because you have been accustomed to addressing each disease separately. With practice, it becomes natural and even streamlines encounters. We will explain how to do each of these steps in the Health Priorities Facilitator and Clinician training slides. For now, we want to give you an idea about what happens in aligning care with patients' health priorities and show you that it does work. We know that patient priority care is effective from experiences in Connecticut and Texas. Decision-making changes when clinicians know what the patient's goals are. In fact, 66% of patients who were cared for by a primary care clinician trained in patient priorities care had at least one decision that was clearly linked to their own priorities. This compared to only 2% in persons receiving usual care. Clinicians are listening to and acting on what matters to patients. It also decreased unwanted care. About twice as many medications were stopped that were not desirable, usually because of adverse effects. There were about 30% fewer diagnostic tests ordered. Remember, that's about a half day in people's lives. And about 30% fewer self-management tasks were added. People also perceived that their burden of their treatments were reduced. But importantly, it's not just about taking away unwanted care. It also means providing care that is wanted if it's going to help accomplish people's goals. In a recently reported study, the Baylor Patient Priorities Care Group at the Houston VA found that self-management tasks, healthcare visits, and community services were added because they helped people achieve their goals. Patient priorities care works. Patient priorities care is also feasible. You may be thinking, I have so much to do already, I can't add anything else. Is this one more thing you want me to do? The good news is, this is pretty much what you're already doing or would like to be able to do. We've just streamlined it and focused it for you. Initially identifying a patient's priorities by any trained member of the healthcare team takes about 20 to 30 minutes, usually in a single visit. You'll learn about this process in facilitator training. For clinicians, we found it added a few minutes over the first couple of visits, but after that, the duration of encounters were the same as before. The time for training and preparing when we were developing patient priorities care took about 3 hours total, spread out over a year and a half with the initial training and then feedback sessions. But we've been able to streamline the training quite a bit as we've learned more. Also important to know that incorporating patient priorities care into practice required relatively modest information technology requirements, suggesting that it can be pretty widely disseminated. Most of the patients and clinicians have liked patient priorities care. For the clinician, they said it helped focus the visits. There's so much going on. If you focus on what matters to the patients, things seem to go a bit easier. It also enabled some consensus among clinicians and improve their relationships. In our initial case, it was between primary care providers and cardiologists. Patients liked the fact that it improved communication between their clinicians and also between themselves and their families. Patients thought the priorities identification visit was more personal than their typical encounters. They also felt that they gained more knowledge about their health and their healthcare tasks and how it could align with their priorities. Most patients felt that over time they could learn to identify their goals and make changes. Not surprisingly, there were challenges, which you're likely to see as well when you get started. Initially, clinicians would ask and say, this is kind of the care I would like to practice, but it conflicts with our metrics. We still get measured on their blood pressure and their hemoglobin A1C. They were also concerned about time pressure, as I mentioned. But after trying patient priorities care, clinicians realized that the time commitment wasn't quite as much as they had predicted, and they got quicker at it. And it did not conflict with their metrics as much as they thought it would. This is probably because people were more adherent to what was now being prescribed. They were also better able to connect their healthcare activities to what mattered most to them. Patients, on the other hand, acknowledged that they were surprised at first. Some people were even a little bit suspicious about what questions we were asking. They often weren't sure what their priorities were because they had never been asked about them before. Some had more difficulty than others identifying outcomes, goals that were specific and actionable enough to act on. You will learn more about that and how to help patients in subsequent trainings. What do patients need to know and do to make patient priorities care work? They need to know their health outcome goals that matter most to them in the face of their necessary trade-offs. They can't have it all, but they can decide what matters most. They also need to be more active partners in decision-making and be realistic and honest about what they're willing and able to do. You'll learn how to help patients do this. As you'll learn more about in the facilitator training, the facilitator helps people identify their values, outcome goals, healthcare preferences, and motivates people to be more active partners in their care. The facilitator can be anyone: nurse, APRN, social worker, medical assistant, or physician with interviewing skills. The initial process occurs usually in one session, occasionally two, over 20 to 30 minutes. This can be done in person, on the phone, or by video. Recent advancements in telehealth makes this easier. The process can even be incorporated into pre-telehealth visits, check-ins with MAs or nurses. We are also developing a self-directed website that patients can go through on their own before a visit or be guided by a caregiver or member of the team. Because it's time limited, identifying patient priorities fits well into busy clinical workflows. A little time up front saves effort, time, and confusion later. What do clinicians need to know and do? They need to learn and understand each patient's goals and preferences by reviewing the health priorities template that's been created for them. Occasionally, the clinician could be the one who helps the patient identify their priorities. Depends upon their own desires. They then need to work with patients, their caregivers, and other clinicians to start, stop, or continue care based on priorities. Clinicians will learn strategies and troubleshooting for aligning care with patient priorities in the clinician training. We are not going to delve into the workflow because it will be different at each site, but these are the core steps to give you a general sense. You can dive more deeply into workflows and billing issues and solutions that we have come up with in our Patient Priorities Implementation Toolkit found on patientprioritiescare.org.